Thank you. Good morning, everybody. I'm Simon Walsh. I'm the Procurement Director for Manchester University NHS Foundation Trust, and it's a great honour to be asked to chair this session. Could I firstly introduce my very distinguished panel colleagues?
Good morning, everyone. My name is Sharon Robertson. My profession is procurement, I'm very proud to say, and I started in the NHS as Director of Procurement for a shared service for 3 provider trusts. I'm now Managing Director for a new organisation based in Lancashire and South Cumbria, where we've brought all of our corporate services together. So that is all 5 corporate services under a single entity. But Scan for Safety has absolutely always been at the heart of where I started within the NHS, and I'm really committed to the health benefits and safety improvements that it can be delivered, and that is why I'm here today. Thank you.
Thank you. Thanks, Sharon. Fiona?
Hi, good morning, everybody. I'm Fiona Hilton. I'm the Director of Best Practice and Engagement for NHS England. I joined the NHS just 5 years ago and led the commercial delivery team initially across NHS England, and recently, in the last 18 months, have been working with the central commercial function across the whole of the NHS system, leading on the strategic framework for NHS commercial with the interventions, of which 2 of them contain the Scan for Safety and the importance of patient safety, and working and collaborating with our clinical and commercial colleagues in order to enhance patient safety.
Thank you, Fiona. Sarah?
Thank you, Simon. So good morning, everybody. My name's Sarah Ford. I'm the Exec Director for Strategy, Change and In-Hospital Services at NHS Supply Chain. I think I need a snappier job title, but that's for another day. I've been involved in all things supply chain and Scan for Safety related probably for 10 plus years now, so I am also a passionate believer in the benefits that it can bring to the health system. Looking forward to today.
Thank you, Sarah. Sharon has just reminded me that the last time we met, one of us was actually getting married. Not me and Sharon, but it was me 2 years ago. So nice to see you, Sharon.
Thank you.
Each of the panel is going to outline their thoughts and views around unique product identification. And then we're going to open it up to questions, both from myself and from the audience. We have about 25 minutes to achieve that. We're very keen for questions. We won't pretend that we are practitioners. We won't pretend that on a daily basis we're going out there using barcodes. But we have the honour and the great fortune of managing teams and colleagues and working among systems that do. So we're very passionate about this subject. So if I can invite Sharon to give a few perspectives.
Okay, thank you very much. So, as I said, I joined the NHS in 2016, and when I started, it was very clear that the logistics and supply chain side of procurement was very much the Cinderella service within procurement, which I always think is the Cinderella service within the NHS. And of course, the NHS is about clinical care and healthcare for our populations and communities. So we are absolutely there to support all of that. But it was very clear that there were some real opportunities in terms of using that barcoding technology. And it was for us to actually drive some of those changes and actually influence our clinical colleagues in terms of making sure that they understood the benefits that were available. And the question that was asked in the previous session about how do we get those clinical teams on board? And there is never one easy answer, and there is never one silver bullet, but you do have to approach those matters and a whole various different set of ways of doing that. The national team, someone mentioned Tim Briggs, really, really important, the GERF team, but also talking to clinicians and getting them to understand what the benefits could be for their patients. So really, really fabulous. So we have introduced barcoding scanning within Blackburn theatres. We've got probably, I think it's 69% of our product is barcoded and scanned within our theatres. We've got a similar level in Lancashire Teaching, which is one of our partner trusts. We've got a business case within Blackpool, again one of our partner trusts, and with the help of NHS Supply Chain Investment, we've got Morecambe Bay as well. So from an ICS perspective, what we are looking at doing is creating an integrated GS1 stock control system, so we can standardise, we can use virtual stocks, we can think about a hot and cold supply chain system moving forwards, but importantly, we can standardise, process and product across all of our theatre environments within Lancashire and South Cumbria. And fundamentally, that absolutely aligns with the principles in terms of GIRFT, best practice in terms of clinical care, excuse me, and making sure that we remove the unwarranted variation, which we've been so good at developing and flourishing within the NHS. So that perspective, that system-wide for Lancashire and South Cumbria is really the direction of travel for us, and we really feel that it's an opportunity to make a step change in terms of the way that we can improve the safety for our patients and communities.
Thank you, Sharon. Fiona?
So I was asked to share a little bit about the strategic framework for NHS commercial across in NHS England. And I just thought I'd share that the central commercial function is essentially a service, a commercial service for the NHS by the NHS. And its support and it provides guidance and support across the system. We set up the strategic framework in November 23 as a 5-year programme to drive collaboration and leverage collective buying power across the whole of the NHS. And it was set up by the commercial community across the whole of the NHS, rather than developed specifically just by the centre, as is often referred to. As I said, it's got 26 interventions, and this year, in 25-26, we have specifically prioritised 9 of those interventions now, because although all 26 are necessary in order to create the seismic change that we need to make commercially across the whole of the NHS, we have recognised that the 26 are all important, but we need to clarify our resources and accelerate on some of the specific critical interventions. And I'm really pleased that 2 of the interventions reference Scan for Safety, which is our reference. We work closely with the Digital Clinical Safety Strategy team, obviously identifying the supply chain benefits and the traceability and patient safety, but also the intervention for the inventory management system that Sarah and her team own across for the strategic framework, which she'll talk about, obviously reducing patient risk, not only looking at the supply chain side of things. I think the original pilots that were done in 2016, we know we've come so much further than that, but there is still so much more to do where we can collaborate with commercial and clinical colleagues, as Sharon and Simon have been so successful with. We know today that we've got suppliers are approximately 90% barcode compliant, but that 10% still is critical in order to be able to be successful with this. So my role within our team is to share best practice, case studies, webinars, in order to be able to encourage across the ICS community and the procurement leaders about the benefits that can be made with the GS1 barcode compliance and the opportunities. We've held recently a Heads of Procurement webinar with Tameside Foundation Trust, who were able to talk about how and the benefits of purchasing loan kits and when and where to be able to do that and how that can make a difference. We also have held recently a GS1 webinar with the procurement leaders in order to talk further about barcoding compliance and the routes for escalation when we find products that are not barcoded correctly. We support messaging beyond just the stock saving, but to emphasise procedure level insight, clinical safety, and cost income alignment. I think really we want to encourage teams to hold suppliers to account to the GS1 and the escalation and support structures that are in place in order to be able to ensure that 90% increases. I had a quote that Lord David Pryor, who was the chair of NHS England, made in 2020, which is 5 years ago. And he said, barcodes are not exactly Harry Potter. Indeed, barcodes are commonplace in most industries and have been around for a long time. It's time they became commonplace in the NHS. They offer traceability, efficiency, savings, and greater patient safety. I think we'd all concur with that and need to remember that was 5 years ago.
Thank you, Fiona. Thank you. Sarah.
Thank you. Finishing on a sobering thought, Fiona. So, as you can imagine, I was going to share a little bit of an update in terms of where we are from an NHS supply chain, IMS and point of care rollout perspective, because I'm sure there are many of you out there who are interested. We were commissioned by NHS England a couple of years ago now to deploy inventory management and point of care data capture solutions in up to 20 different trusts. And I'm delighted to say that, given the very, very hard work of teams in trusts, our teams, the technology providers, we're now live in 10 different locations. We are very busy summer ahead, still a lot more to do, but I think what we're finding is the benefits are in excess even of what we had originally anticipated. And I think the last section was really interesting, talking about how you position this both within trusts and at national levels, and I think that's part of the key that we collectively need to unlock. At the headline level, we know there's well over £1 billion worth of stock held at the front line in trusts, and we know at least half of that is unmanaged by technology, managed and best endeavours by humans. And what that means is there is roughly 30% stock in excess of what needs to be tied up on the front line, and we know that there's 10 to 15% of obsolete and expired stock on the front line. So if we could capture those benefits purely from a financial perspective, those can be realised within the first couple of years of implementation. So maybe not within a single year, but pretty close. And I think part of what we're trying to do is help individual trusts create business cases that unlock the financial hurdle to get started, but connect it to the imperative and the benefits around safety, around clinical variation, connecting into FDP and the medical device outcome registry. So part of what we see our role as being is being the ingestion of that data, to use that data for many, many sources. This is absolutely not about supply chain and inventory management. This is absolutely about patient safety. But unless you can get it started in a meaningful way and through those governance hurdles that everybody has within trusts, you can wax lyrical about the benefits that exist. But if you can't get it going, we're not able to leverage those. In addition to rolling out the solutions, we've also been working hard on data. So we, over the last 12 months, have captured another, I think, 86,000 GTINs into our solutions. That means 92% of our catalogue now has the right GTIN data in there. It's really important that we capture it in the right way and it stays current, and we can therefore flow that through technology to the places that need that information. And we're also working increasingly closely with FDP and the medical device programme. I think it's really important, again, nationally, we think about how we build these architectures and solutions to make it as efficient and as simple as possible for people on the front line. You don't want to spend time capturing information through scanning multiple times or retrospectively entering data. So let's design it as a whole and make sure it makes sense and it's simple and efficient to use. I think the final thing I just wanted to flag, and I'll preempt a question, what happens next to the programme? Are you getting more money? I would love to have a crystal ball right now, and I don't, unfortunately. I guess what I can share is the business case is compelling at a trust level. The people we're working with are delighted. At a central level, the benefits are well recognised, and I think we just need to let governance processes play through the spending review to land, and we hope to have some more information in the next 2 to 3 months.
Thank you, Sarah. Thank you, Fiona. Thank you, Sharon. We're in the final countdown. We know that Scan for Safety, product identification, improved traceability, delivers financial and non-financial benefits for the NHS. The question to you, the audience, is how do we drive that forward? And how do we take that message across the system with the learnings that we've shared from this panel, but also writing back into the NHS after this conference? Before we open to questions, is there 1 or 2 words of advice that you would give colleagues to drive that forward in the trust or organisation?
Yeah, I would. So I would say we're all, whether we like it or not, human beings are tribal. And increasingly in my career now, and I wish I'd known this at the beginning of my career, if you want to convince an accountant, you get an accountant to talk to them. Similarly, if you want to convince a surgeon, you get a surgeon to talk to them. So that would be my 1 point of advice.
Thanks, Sharon. Fiona, advice?
Yeah, I think the evidence of the business case, of the financial benefits. I'm a commercial person and absolutely concur that clinical colleagues talk to clinical colleagues, but ultimately the CFO makes decisions. And I think it's having robust business cases that can be evidenced and proven in order to be able to take things forward.
Thank you, Fiona. Sarah?
I was going to add, don't overcomplicate the business case.
Yeah.
And learn from the excellent practice across everybody in this room. Start small, get it over the line, get started, but build a vision that takes you all the way through to the safety, the clinical variation, the outcome benefits that are ultimately what we're all here to enable.
Thank you very much, Sarah. Thank you, panel. We're now going to invite questions from our audience. If you can introduce yourself, if you manage to grab the mic, and any questions either on what's been said or your thoughts. Sir, thank you.
I'm Neil Lawrence. I work as a consultant now, but some
nice
20 years ago, I led the Code of Success work that kicked this off. I'm slightly horrified that nothing much seems to have changed since then, but you've just coined it perfectly. We are a tribal people, the Brits. We are incredibly stubborn, and we hate
I don't think
being
it's
told
just the
what to do.
British, in fairness.
No, not at all. So how do we get that Mance Raider figure at the top that can get everyone on the same page? Because the previous panel had the same problem. You should do it like this. We are doing it like this. You didn't do it like that. Those were the 3 points of view that we had. So how do we get to that point of someone at the top saying, you're all going to do this, and that's it?
Thank you very much. I shall start from my far right, work along.
Well done.
And I would start by saying we're trying. That's exactly what we're trying to do. There is so much compelling evidence. It's just an incredibly challenging time, as Alistair, I think, painted the picture at the beginning. And it being logical, entirely the right thing to do, I don't think is enough right now. So I think it's a coupling of that with individual circumstance. I think we're also observing there's a big delta between trusts who are ready for this and trusts who are not. Those that are ready and have sponsorship and a clear plan move 2-3 times as fast as those that don't. So I think we collectively need to work top, middle, bottom, and play to the different strengths that we all have and you all have out there, and keep working together as a community. That's part of one of the things that supply chain are trying to do very passionately, is bring together communities, because it's no one single person's job. We need to work as a team to get this thing done.
Thank you, Sarah. Fiona?
Yeah, I completely concur with what Sarah's saying, in that we have got a national health system, but we all know that we're all in very, very different places. And I think it's impossible to say one size fits all, and it needs to be done bottom up specifically. And some areas are very successful currently, as we know, but we need to work individually in order to be able to land something successfully.
Thank you, Fiona. Sharon?
So I can't comment on 20 years ago, but I can comment in the last 10 years, and there has been massive change.
Yeah.
So I really disagree with that statement fundamentally, and I think Central have got to be given credit for the fact that they actually asked supply chain and made sure that there was monies available. But I would also recognise, in terms of Andrew and the rest of the executive board at NHS supply chain, it's been a game changer for us, because a lot of trusts were doing it on their own, and it's made it much, much easier. And this has to be a national platform fundamentally.
My name is Ish. I happen to be a bloody surgeon. I'm at North Tees. And I think at North Tees, we've been on a journey, and we've been on this journey for 10 years.
Yes.
We started with our EPR 10 years ago, and I think if we look at how we get clinicians on board, I think it's a chain. You have to start from the top. So your chief executives, medical directors, everyone buying in to your digital mindset. So we have a very proactive clinical informatics group with CCIOs, with chief clinical informatics officers, clinical safety officers, etc. We deployed our own scan for safety solution. It's called CareScan. Probably about 7 years, six or 7 years. And we're now adding more and more elements to it. Now, I happen to be at an interface. I'm part of the digital team. I'm part of the patient safety team. I happen to chair the NATSIPS committee, where we look at invasive checklists. With the HCIB report, we've been looking at it. Some of the things, for instance, how do we develop things? Learning from mistakes, learning from events, and turning it into a solution. So I'll give an insight of some of the things we've done in the last 18 months. So about 18 months ago, we had a never event around a mismatched joint prosthesis. So you have, for instance, in a knee replacement, you need 4 different components and the sizing has to be matched. And at the minute, it's a manual process. The surgeon looks at it and decides, yeah, these are the proper sizings relevant to it. And the procedure was done. Now, the implants are added to the National Joint Registry at the end of the day by the teams. And that's when it was noticed that the implants were wrong, were mismatched. So we've been working with the NGR. It's still in pilot phase. What we have developed is a proof of concept where as we scan the product, it will ping in real time with the NGR, which means that if there is a incompatibility, it will flag it up to us. So these are things that we are doing. And again, we've got a lot of experience to share. We've got Tony Naylor, who's led the project. Please
Thank you very much.
Yep.
Thank you. Thank you very much. Thoughts? I think firstly it's absolutely fantastic to hear this gentleman's tales and stories. I think it absolutely brings us down to the right focus of what we're trying to achieve. So thank you for sharing that. Sharon, thoughts for me, please.
Sorry?
Thoughts on what the gentleman...
Well, I think it's, again, it has messages along with the previous panel, which is it always has to come back to the patient. And it always, as long as we keep that in our line of sight, we continue to make the right decisions and take the right actions. But can I just say, in terms of having a bloody surgeon in the room, it is fabulous to see the level of enthusiasm and commitment to actually make it work, but not only do the basics, take it beyond. So thank you.
Yes.
Thank you, Sharon. Fiona?
Yeah, agree. I'm not going to add anything. I think it's really,
Thank you, Fiona.
agree.
Thank you. Sarah?
No, Sharon captured it perfectly.
Thank you very much. Thank you, sir. A question at the back, I recall. Thank you.
Hello. Yeah. Hi. Jack Searle from the Health Service Journal.
Hi, Jack.
Hi, Simon. Just wanted picking up a bit on the final comments on the first question, but also some of the remarks from the stage about the potential for using these sorts of programs at an ICS level. And we've been told for several years now about the potential benefits for ICSs in procurement, in Scan for Safety, because you can start to look at the whole patient pathway, not just what's going on in your individual organisation. However, just earlier today we heard how ICSs are, essentially being unwound. At the least, they're going to go through massive upheaval and turmoil, mergers, job cuts, that sort of thing. So, Fiona, I just wanted to know if you could tell us what's going to happen to ICS-based procurement now? Is it going to continue? Is it going to pause? Heaven forbid, is it going to start to be unwound? Are we going to start to see trusts having to operate in isolation again, starting to hopefully adopting things like Scan for Safety, but not then sharing that across their footprint?
Thank you, Jack. I'm sensing a HSJ headline coming up here, Fiona, so you might have to be slightly sensitive. So Fiona, then Sarah, and then Sharon.
Hi, Jack. Yes, no. I'm sure you're aware at the moment we've got a transition executive team that Jim Mackey is leading, and we are yet to publish and determine exactly how we're going to integrate NHS England. And you've seen, along with all the published media that we have put out there at the moment, that we are currently working through how it's going to be structured and what will be the optimum solution for integrating NHS England across into DHSC, but how the ICS leads and how the procurement and regions will collaborate and work together. I suppose what I do know is we need to be more efficient, and we recognise that, and we work today very, very collaboratively with all the ICS leads and with NHS supply chain. And I would say in the last few months where there has been this uncertainty, I would say it's encouraged us to work even closer, because there is still this huge £35 billion worth of spend that we need to ensure we are efficient and leveraging our buying power but working together. So I can't tell you specifically, and I would ask you to be a little bit further patient along with everybody, frankly.
Thank you, Fiona. Sarah, then Sharon.
I would just say that the fundamentals of what it is we're trying to buy, the supply markets we manage, the resilience challenges we're managing, don't change. It's almost how the goods are consumed and how people work together to bring those solutions into the NHS. So from our organisation's perspective, it's not BAU, but a lot of the same things still remain, and we need to stay focused on the bold strategies from a category perspective that will drive the biggest impact in the right way in a relatively short time frame, and then work with colleagues as they go through the journey in terms of how that gets consumed. So clearly, clinical adoption is critical if we're going to really get to the bottom of some of the efficiencies that exist, and that is influenced in the way that the system is structured. But there's an awful lot that can still be done in the meantime.
Thank you, Sarah. And finally, before we close.
So there's no headline in this, but fundamentally we have to reduce costs, and that includes cost of payroll. So rather than reverting back to doing something 5 times for 5 trusts, the solution has got to be to do things once for 5 trusts and really use that sort of modelling to aggregate it up. And where that will take us in the future, no one knows, but fundamentally today we have to start doing that, and I can't imagine that there will be many places who are wanting to retrench backwards into an individual perspective because simply there isn't the money there to grow those corporate services.
Thank you, Sharon. Thank you. Ladies and gentlemen, it's been our pleasure to host this event. Before I leave, can I just give a personal thanks to Glenn Hodgson, who we know is moving on to pastures new within the organisation, but on behalf of NHS Procurement and on behalf of the Healthcare Supply Association, of which you've been a passionate supporter, thank you for everything you've done for NHS Procurement and NHS Procurement teams. Thank you.